plan. First of all, I would like to thank all the contributors of this plan.
Gero, you're muted. You're muted.
Can you hear me now?
Yeah, but there is an echo.
Can you hear me now?
Yes.
Okay, good. So you haven't heard anything of what I've said so far, is that right? Okay,
Correct.
let me start again then. Sorry about that. So welcome everybody to our session today, which is about rolling out our global GU tumor strategy plan. I'd like to thank all the contributors that have worked with us on this plan. I believe over 60 colleagues across 5 asset teams, colleagues from global, region, and of the markets. So we hope this is going to be a plan that is also highly relevant for you in the markets, and we are very much looking forward to hear from you, your thoughts and your feedbacks. For that, we'd encourage you to make frequent use of the chat. We'll try to respond as quickly as possible in the meeting to make sure we get some good interaction and really hear your thoughts about this plan. The plan that you're going to see this year is different to what we've done in the previous years. Last year, we had a prostate-only plan, and again, acknowledging some of the feedback we've had from you guys, we have this year opted to do a global GU TSP plan in which we are reflecting both the needs from the bladder disease area and the prostate disease area. We believe that this has been a really good way forward, as we are seeing the same customers across these two disease areas. We are operating with the same country teams in these disease areas. And as we have found out during the work on this TSP, we are also facing very similar challenges, and therefore it really makes a lot of sense to have one integrated global GU tumor strategy. Due to this approach, we really built a new plan. We started from the bottom up, came up with 3 completely new SIs that you will see today in this plan, and we really need to understand how relevant these are for you. And based on these 3 SIs and based on the rich pipeline we have in GU cancers, we are also very proud to show you today a growth ambition in the midterm for the GU disease area that is quite compelling and potentially a path for us to become the leading company in GU cancers. Good. With that, let's dive in. Let's go to the next slide. Just briefly summarizing again, what is our ambition? What do we want to provide to patients in the GU disease area? We have the potential to treat 1 in 7 prostate cancer patients and 1 in 10 bladder cancer patients within the time period by 2030. We have a rather unique pipeline with regards to the diversity of different MOAs that we have in our portfolio, spanning PARP inhibitors, spanning immunotherapies, AKT inhibition, antibody drug conjugates, bispecifics, and the most recent addition of radioconjugates. There's really nobody that can follow us on that diversity. And then, of course, the opportunities that arise from combining all these different modalities that makes us really stand out as a company, and is really delivering a very compelling picture for the future. That ties into our mission on what we want to deliver also for the business. We project currently a compound annual growth rate for the disease area in the ballpark of probably some 25 to 30% in the next couple of years midterm. And that could potentially be followed, as we'll see in a minute, by really even more pronounced growth in the years after for transformational impact within this disease area. Let's have a quick look at how this comes to us in terms of sequencing of assets on the next slide. So today we are represented within the markets for prostate cancer in castration-resistant disease with PROfound and PROPEL, where we are leading the modality of PARP inhibition. We have made a fantastic start into the bladder cancer disease area with Niagara. And bladder cancer is really the area where in the short term, 2026 and 2027, we have immense opportunities and where we really need to make sure that all of our focus is directed towards the launches of Potomac and Volga and making sure that our teams in the countries have all the resources that they need in order to be successful in this really very highly competitive market environment. We are similarly curious, of course, to hear how our filings for CAPI-281 are progressing, and we'll hope to hear more in the coming weeks and months about the launch of CAPI-281, which could be an important step for us to have the first indication in hormone-sensitive prostate cancer, a new disease area for us, and the area where we will then hopefully enter with saruparib. Mid-2027, we are expecting high-level results for saruparib, and we will know whether we have an active competitive compound here in this disease area. First launches for saruparib are currently projected to occur late 2028. And this will then followed soon after by our next high-level readout for AZD2265. That is our first radioconjugate alpha emitter that can then potentially launch later in 2030. You will see then it's not within the time horizon of this BSP, but there are many follow-on indications for both saruparib and AZD2265 in the years after 2030. There are several additional new modalities that are being explored within the disease area, spanning further ADCs, spanning CAR-Ts, T-cell engagers, and novel hormonal therapies. Plus, I believe also new bladder cancer programs that are not yet reflected here, if I remember correctly, Kelly, right? Good. All right. So this is how it looks from a asset sequencing perspective. How does it look like from a market ambition growth perspective? This is what we are seeing here on this slide. And we like to talk to this slide in two phases. A first phase, which we refer to as the build phase, where we really have to build the very strong foundations for being leaders within the GU disease area, where we are competing versus very established other players that have a heritage in this space. And it is in that first builder phase, which stretches from pretty much right now until 2029, 2030, where it's our bladder assets, in particular Potomac and Volga, that will be driving the strongest growth momentum. Then, of course, also the opportunity with CAPI-281 to further increase that growth momentum. We will most likely see the patent expiry of Lynparza towards the end of 2029, then marking the transition of that phase from a builder phase into a phase of potentially more accelerated growth. That is really the scaling phase, where we then have several new asset platforms kicking in. The first one is being Saruparib, which has the potential to become a multi-billion-dollar asset across different indications. And then most notably, our radioconjugate program, which we will launch in several indications in prostate cancer, overall leading us to a potential for revenue in the ballpark of $16 billion by 2034. This is, of course, not risk adjusted, but I would also like to highlight that there are many phase one, phase two programs that are currently progressing in our pipeline that are not yet reflected with regards to the revenues they could potentially generate in that second period. So plenty more opportunity to really make these 16 billion or even more revenue a reality for us. Now, in the near term, when we look more at the launches of Potomac, for example, but also for Saruparib, we're acknowledging that we are doing a bit of a shift in that we are moving earlier within the disease areas of bladder cancer and of prostate cancer. And that comes with interacting with a new class of customers that we have probably not focused on so much in the past, and that is urologists. Kelly, you want to tell us a little bit more about what we know about urologists and how that is going to change things for us?
Of course. Thanks, Garo. So yes, this is going to be an exciting new customer group for us. Many of you have been interacting with urologists either with Lynparza or some of you even with Zoladex. But as you will see, we are going to become even more acquainted with this key customer group. If you want to go to the next slide, Garo. I think just focusing on the build phase, so that 2026 to 2030, you'll actually see that the sales revenue is split evenly between bladder and prostate cancer. The other thing you'll notice is that as our revenue is increasing, the proportion that's driven by urologists is increasing as well. And as Garo mentioned, that's really driven by the type of disease that we're going into. So for prostate, going further into hormone-sensitive prostate cancer, and for bladder, going into non-muscle invasive bladder cancer. Both disease states are primarily treated by urologists. And the reason why that's important, if you want to move to the next slide, is that really the training and underlying motivations between these two groups really translates into how they make treatment decisions and how they evaluate the different options that are available. So oncologists we're very familiar with. They are really driven by innovation, and they're excited by that incremental improvement that we can make for their patients. Urologists, by contrast, are really surgeons first. So they're looking for tangible results, something that's easy and easy to manage and simple for them to give. So really two different ways of looking at how they provide benefit to their patients. One of the asks that we're going to have for all of the markets is to really take a deeper dive into understanding the urology space within your markets. So you'll see at the bottom, we've identified at least 4 different archetypes of urologists in terms of how they interact with oncologists, and specific for Imfinzi, how they might have access to infusion facilities. So that can vary everywhere from having a very integrated multi-specialty type clinic, all the way to that single urologist working in a small community. Excuse me. And what you'll see on the right-hand side is some of the work that the US team has done to really look at how do they dissect that urology community, which is quite a large audience, and look at where we might have synergies across the different brands and indications that we have. And you'll see that really the idea is not to call on all urologists, but really to identify those where we might have multiple opportunities and those that really have the types of patients that our medications are going to be good with. So we use the phrase fish where the fish are. One example of that for Potomac is that the US has found 65% of their urologists don't have access to infusion facilities or work closely with an oncologist, which at first can seem like a major challenge that the team is going to have. But when you actually do a deeper dive, you see that those urologists actually only prescribe 30% of the BCG usage. So ultimately, that team is making the decision to not call on those urologists as a key target. So again, that's just an example of how they've really dug into understanding the dynamics within the urology space. Next slide. So what you'll see is that the plan that we've put together really is built off of that common urology platform and this so what and implications that that means for our brands. So as we're moving to earlier disease states, these are larger patient groups, and what we're finding is that urologists are not comfortable in giving these intensified treatment options to all patients that might be eligible. So one of the things that they're asking for is tell us what patients are going to benefit the most. And those could be through biomarker testing, or it also could be through different types of risk stratification, but they really want to identify who are the specific patients that are going to benefit and are concerned about not overtreating others. The other consequence of moving to more of a urology-driven treatment areas is that these are physicians that, you know, by sense of their training, aren't maybe familiar with some of the consequences of systemic therapy. So how do they manage adverse events? While they're asking for ways to find that patient, they might also not be familiar with biomarker testing. So these are all things that we need to help them with so that they can identify patients, but also safely manage patients when they put them on these therapies. The third insight is around collaboration. So you saw on the previous slide how there are different archetypes that exist, but even within those different archetypes, there's varying degrees of coordination between oncologists and urologists. And this is something that we really need to improve. So unlike lung cancer, where there might be MDTs that are set up, that are more formalized, what we find in these disease states is that the connection between urologists and oncologists is really more relationship-based. So we might not be looking at changing that and shifting the entire space to formalize MDTs, but how do we better improve those connection points between those specialties, and how do we make sure that the patient experience is more seamless? And this is going to become even more complicated as we progress with our pipeline. So currently we're focused more on oncologists and urologists, but you can imagine once we move to radioconjugates, you're also adding nuclear medicine suites to that dynamic as well. So the work that we're doing now is really going to be a great foundation for when the complexity increases. Next slide. So we are not alone in being in this space. And I think the GU cancer area is actually a very exciting place to be right now, because there are so many new medications that are coming and a lot of great science that's happening at every single Congress. From a bladder perspective, our main competitors are Merck or MSD, Pfizer in partnership with Astellas, and J&J. And I think you'd have to be living under a rock to not hear all of the excitement that is around EV, currently in combination with Pembro. But we also have another EV, durvalumab, a combination with Volga, that is coming very shortly and is going to allow us to play a leadership role in that space based on the unique trial design that we have and the combinations with Tremi. So stay tuned. We're going to be competing head-to-head in that space. With J&J, they're appealing to urologists in a different way in terms of devices that really speak to the underlying, motivations and things that really sort of interest urologists. So you've probably heard of the Pretzel device, TAR 200. This is a platform that they are currently using with gemcitabine, but will also have other treatments in their pipeline. And this is something that will compete with Potomac in the non-muscle invasive bladder cancer space. Carol, what about prostate cancer? How do our competitors look there?
Yeah, similarly competitive in the prostate cancer disease area. The first competitor that I really want to talk about is Pfizer. And many of us have already gotten into the swing of competing with Pfizer, as we're up with Propel to defend our market leadership in castration-resistant prostate cancer versus Talapro-2, Talzenna. This battle is going to continue. We have recently seen the press release of Talapro-3, which is the entry of Talzenna into the hormone-sensitive prostate cancer space, which is exactly the area where we will launch with Saruparib. So it's critically and important that we make a great job on competing today versus Talzenna, as that is going to be the same competitor for us in the future to be successful with Saruparib. It's important to note that Pfizer is really running a big business in prostate cancer. Xtandi sales alone are over $4 billion. It gives them also really good insights and heritage with the urologist community in hormone-sensitive prostate cancer. So Pfizer is really our key near-term competitor for our prostate cancer assets. With regards to Merck, we don't know too much of the asset that we have listed here. Some investigators are not too impressed with opevesostat, therefore maybe a bit of a question mark how much of a competitive threat that is going to be. Johnson & Johnson does have a really interesting pipeline in prostate cancer, exploring completely new treatment modalities. So that will be interesting and important to watch. Then the other really key competitor for us as we are pivoting into the radioconjugate area is, of course, going to be Novartis. Novartis has been the pioneer for radioconjugate therapy with Pluvicto. Pluvicto is a beta emitter, so a first-generation radioconjugate asset. We will not compete on beta emitters. We will compete on the next generation of radioconjugate assets, the alpha emitters, which are emitting at a shorter distance, potentially resulting in less collateral damage of tissue and less side effects, while at the same time irradiating a higher energy, therefore a higher potential for tumor cell killing capacity, and therefore really the future of radioconjugates. Novartis also has an asset in that area. We are quite on par with regards to potential launch dates, and we do believe that there are some aspects to our compound that are positively differentiated versus Novartis. Let's look a little bit more on how competing is going to look like at the asset level. Can we please go to the next slide? And here we are looking specifically at how the hormone-sensitive prostate cancer disease area is going to shape up. This is a disease area where we are looking at survival of patients in the ballpark of probably 4 to 5 years, for some subgroups even longer. So I just want to mention that in the light that it is going to be more challenging in such a patient population to show survival benefits, and we would probably not expect to see significant improvements in survival benefits at the primary readouts of any of these trials that are running in this disease area, but most likely we'll see that later along the time spectrum for later data cuts. Now, the way that patients are being treated for hormone-sensitive disease is with an ADT and an ARPI to really inhibit that hormone axis that drives the disease. These are also the agents that are causing really a lot of side effects and a lot of complications in men when you sequester all of that hormone from their bodies. The approach that we and others are taking here is that we are leveraging additional genetic information about these patients to add further compounds and intensifying therapy here. For PARP inhibitors, we will do that with adding PARP inhibition, like TALAPRO-3, and for EvoPAR-01. In the case of TrueCap, we explore the concept of AKT inhibition. This is specifically indicated for patients with PTEN loss, and therefore the co-positioning suggests that TrueCap is going to be the agent, the regimen of choice for PTEN deficient patients. Then the next critical marker in these patients is HRR positivity. We believe that most likely saruparib is going to be the leading asset in this subgroup of patients. And then, of course, we have the subgroup of HR negative patients with or without PTEN loss. For those that feature PTEN loss, we will have to see how the data pans out in the subgroups for TrueCap and saruparib to decide about that co-positioning. Just another word on how we are competitively positioning saruparib versus other PARP inhibitors. We are, of course, developing the compound in a manner that we can possibly show a better risk-benefit profile. Saruparib is able, through the way it's engineered as a PARP1 selective agent, to achieve higher inhibition of the PARP1 target than other assets. We believe to see that there are potential safety benefits of saruparib versus other PARP inhibitors. We see that saruparib is more easily combinable with really the whole spectrum of available ARPIs, giving physicians the full choice of their preferred ARPI. That is not possible with other PARP inhibitors. And then last but not least, other PARP inhibitors are all developed selectively and only in biomarker subpopulation of HSPC disease. Our EvoPAR-01 study does have an HR-specific cohort, but we also do have a cohort of biomarker negative patients to explore whether our PARP inhibitor drives benefit also in biomarker unselected patients. So much for the picture in hormone-sensitive disease. Let's also have a look at the CRPC disease area, how that is going to shape up on the next slide.
Right, there is a question. There is a question in the chat. I'll start with the prostate one. What is our strategy for radioconjugates, especially how we are addressing competition from self-built imitators, such as Curium, Sebersdorf?
So that's actually exactly what we're seeing on the next slide. Here you can see how we are going to make an entry with radioconjugates into the disease area. The Vectra-1 study is in a patient population for last-line patients within CRPC. So this is a post-ARPI and post-chemotherapy. It is simply for the reason it's the fastest way to access. This is where the highest unmet needs are in the disease area. But we will then, in the years after 2030, this is just a picture until 2030. In the years after 2030, we will then also read out studies that are in the earlier stages and in the first line setting of metastatic castration-resistant disease. Now, you may be asking, we have already seen the PSMA addition data from Novartis in hormone-sensitive disease, and we've had extensive discussions with the clinical community around their interpretation of the data, and so far it hasn't landed in a way that people would think that either PSMA addition or radioconjugate therapy in general would be a new standard of care in hormone-sensitive disease. Most of our key opinion leaders really see that this is more of a modality for later stage disease in the CRPC setting, much of which is founded on the notion that there are long-term toxicities that really start to weigh in high if you are treating patients early with this. Now, the second part of your question you mentioned is around what are we going to do about sites engineering their own radionucleotides, radioconjugates. Do I understand that correctly? So this is something that has definitely been observed in the past, and we need to be very clear with regulators and physicians that in a setting where a company has done a randomized controlled clinical trial showing the superiority of a radioconjugate, that is a very different evidence base than a hospital somewhere manufacturing their own assets. Now, so this cannot be compared to each other from an evidence level, and therefore, wherever a randomized controlled study has been done, the approved asset should be given priority for the use in patients. Lisa, anything to add from your side?
Yes, thanks, Gero. Maybe definitely that is an important area that we have already captured within IBT. We have just formed and kick off the IBT for Zadagu. We are well aware of this challenge, and on top of what Gero just shared, we know that there are countries, for example, Germany, where this is allowed. So we will need to play around the local regulation and understand how we can prevent this situation or minimize the impact of this situation. So it will be a quite tailored approach based on the country and the local regulation. You will also see more coming in terms of strategy, but definitely the pillars will be around building the internal capabilities, because probably now that you have started approaching the radioconjugates space, you have noticed that is a very complex area, but at the same time very different from other areas we are used to in the geo space, like a small molecule and antibodies. And also the element of ensuring a positive experience for both patient and institution will be critical and a pillar of our strategy, because the time window between the moment the drug leave the manufacturing facility and when the drug needs to be administered to the patient is very, very short. So the experience needs, the process needs to be very, very smooth. You will see more around this coming during the year, so through IBT, and I will touch a bit about that later in the presentation.
Maybe just one more thought, Lisa, and this is just about thinking out loud, but the next generation of radioconjugates are going to be alpha emitters. We've heard a lot that sourcing actinium as an active ingredient is very difficult. So that may make things a little bit harder for people that are building their own radioconjugates. Also, handling may be quite a bit easier for an alpha emitter than from a beta emitter, because it doesn't cause many of the headaches that we've seen with the beta emitters, potentially extending the amount of sites that are going to be able to work with us in providing these therapies. Maybe shifting a little bit away the focus from a few big sites today that are able to do their own radioconjugate compounds. Good. Then we had a bladder cancer question as well, right? Or have we already addressed that?
That will also be addressed on the next slide with Kelly and Lisa.
Good. Let's do that. Let's move on then. let's skip this one.
Yes. So switching. Sorry, Kelly, do you want to say something?
Go ahead.
Okay.
Go ahead, Liz.
Switching gear and looking at the situation and the situational analysis for bladder cancer, we are in a different situation here compared to prostate cancer, because you will see that the co-positioning will be less a challenge for us, while we have a portfolio that allow us really to support the patients and provide a valuable option in all stages of disease. So starting with the left far side of the slides here, the non-muscle invasive bladder cancer space. This is where the majority of patient is diagnosed, because we are talking about 70-75% of the new diagnosis. And this is an area where patients have overall a good prognosis, but the unmet need is there for these patients, because for nearly 4 decades, the main treatment for this patient with a high-risk disease has been BCG. And for those familiar with this area, you know that BCG might be a quite invasive treatment, because you have periodic instillation, but also at the same time, the outcome for these patients are still affected by high recurrence rate in the first couple of years. So definitely there is room for improvement. And here is where we have the possibility really to establish a new standard of care with the Potomac. Potomac is our registrational trial looking at Imfinzi in combination with BCG. And that show a benefit in this population with us as a ratio of 0.68. So this is where we can show the benefit for the patient, but at the same time is where we can really engage the urologist, who are the main player in this specific stage of the disease, to really showcase the value of adding Imfinzi to the current standard of care to improve outcome for the patients. There are other studies with immunotherapy agents in this space. We saw results from CREST. So this is a Pfizer study, but we saw a similar as a ratio, but a different safety profile. And we know that at the moment they have withdrawn their submission to both FDA and EMA. So waiting for more mature data, longer follow-up. So this will give us an opportunity really to be the first in this space. And while we are also waiting for results from the Keynote 676 study with Pembro. Moving then to MIBC, here we are looking at patients with a more advanced disease. It's about 20-25% of the new diagnosis. And this is where the scenario is getting more crowded. So Kelly has already touched some of the key competitors that we have in this area. We are waiting for additional data readout, but from an AstraZeneca perspective, we have 2 main trials in this area. We have Niagara. Gero already touched around the successful launch, and with Niagara, we have established for the first time the perioperative concept in MIBC, showing a benefit in Niagara benefit in overall survival for the first time. And then is where we can really complement Niagara with Volga. While with Niagara, we are looking at patients who are cis eligible. With Volga, we are looking at patients who are cis ineligible or cis refusal. And in this case, we are proposing a regimen that is quite innovative, because we are looking at a perioperative approach with Imfinzi and EV, plus or not Imjudo in the neoadjuvant space. But the big differentiator versus EV Pembro trial will be the fact that we don't have EV in the adjuvant phase. So this would help really patients to stay on treatment and be less affected by the safety profile with EV. As mentioned, this will be a quite competitive space where the main player and probably the biggest competitor for us will be EV Pembro regimen, base regimen. In this case, both for patients with CIS eligible and CIS ineligible. In this case, what we are expecting is an evolution of the criteria to define the eligibility of the patients. So we expect a potential evolution from a classification based on the eligibility to CIS towards a system where patient will be selected based on their eligibility to EV. So this is something that definitely will require monitoring, and where we will ask the country also to provide insights on how the landscape is evolving at local level. Then moving to the metastatic stage of the disease, here we have about 10% of the patient diagnosed in this specific setting. So in this case, we saw very compelling results again from the combination of Pembro and EV that showing benefit again in overall survival. But here we have the possibility to contribute and bring benefit for the patient, especially patients with PD-L1 high, with our NILE study, looking at the combination of Imfinzi plus chemo, also in this case minus or plus or minus Imjudo. Here, what would be interesting to observe in the near future is how the treatment landscape will change with EV Pembro moving towards earlier line, so specifically the MIBC stage. So how physician will approach sequencing of treatment, for example, for those patients who are transitioning from MIBC to metastatic urothelial cancer. And very important also to flag that we have an HER2 in this space with the DESTINY-PanTumor02 study with a tumor agnostic indication. We had FDA approval, and the use in the US is showing very positive signals. We are waiting for EMA approval, and this is an opportunity to provide benefit to patients with HER2 overexpression, specifically for 3+ patients. These are patients heavily pretreated, so they have a very limited option, and bringing an HER2 in this stage can help improve outcomes for these patients as well. Okay, moving to the next slide. Sorry, there was also the question around the bladder cancer strategy. So as Kelly mentioned earlier in the chat, we expect more coming to this space. Definitely, we are looking at the bladder cancer space from a ADC perspective. There are assets also in early stage of the pipeline that could potentially see adoption in the bladder cancer space. Even the radioconjugates have a potential an application in this specific area. So there will be more to come. Just stay tuned, because I think we will be able to release more for bladder cancer in the near term. So is definitely we have several assets that could potentially bring a benefit to patients with bladder cancer. If we can go to the next slide, Gero, we are switching gear here because we have seen the situational analysis. So what we are observing today and how we expect the treatment landscape will evolve. But based also on the current situation, the insights that Kelly presented, we identified 3 pillars for our strategy. So one of the first pillar is really empower physician to being able to adopt this novel treatment in earlier stages of disease, because our portfolio for both prostate and bladder cancer is moving towards earlier stages of disease. So empower physician to make a decision and be able to adopt a new treatment option based on biomarker profile of patients, and these apply especially to the prostate cancer portfolio, or based on clinical factor or benefit risk assessment. So the approach is very personalized, is even beyond the disease stage, is really at patient level. So every patient should receive the treatment based on their specific risk, and patients with a higher risk of disease, of recurrence or progression, should be treated with an intensified approach. The second pillar, I believe this comes with no surprise, with urologists getting more and more relevance for our portfolio and in the management of these patients. We really wanted to put a huge focus on really elevating the urologist capabilities, because we want urologists to be more aware of the option and more aware of the unmet need for the patients that they treat in their daily practice, and empower the urologists in order not only to refer to the medical oncologist, but in some cases, in some stages of disease where they have a more prominent role, really drive treatment decision based on belief and based on really recognizing the benefit that the intensification of therapy can bring to their patients. So we want to work and bring more awareness, but also more confidence in looking at these systemic treatments and managing toxicity. The third element, the third pillar of our strategy is around really strengthening the GU care pathway, with more stakeholders coming to the table to manage these patients. And I'm thinking also about new specialties like the nuclear medicine for radioconjugates. The treatment pathway for the patients are becoming more and more complex and are not always optimal. So we, as an organization, we wanted to commit really and partner with the scientific community to build a journey, to build a pathway for the patient that are smoother, but also allow the patient to receive the best treatment for their specific risk profile. So moving to the next slide, how the success look like based on these three strategic imperatives. Here we have depict some of the critical success factor, and we have tried to give sort of timelines to help also the countries really orientate around, navigate the different priorities. So when we look at the first strategic imperative, today we are in a situation where really many physicians don't have an adequate perception of the benefit risk of their patients and the need to intensify the treatment approach based on the risk of these patients. And as we say, that the risk can be driven by having a specific biomarker or clinical characteristics that drive a higher risk. So we really need to change the perception of this physician, and this will be a high priority as organization. And of course, this will trigger also the need to work on how to identify this patient. So this means ensuring that we have they have testing platform in place to identify biomarkers, but also being able to really assess at patient level based on the benefit risk profile. So these require a different level of awareness and belief also for physicians to approach patients in this way. So is there a question? So ideally, this in the future should translate in clear recommendation from the guidelines that are both clinical guidelines, so for the urologist, the medical oncologist, but also for the pathologist, in order to incorporate both testing and benefit risk assessment in their daily practice. When we look at the second strategic imperative, Kelly mentioned that the urologist is a relatively new group of experts for us, so we engage with urologists for some of our assets, but this is really an area where today we don't have a very comprehensive understanding of their motivation, their belief, what are the challenges and the barriers in their daily practice. So definitely one of the key areas for us would be try to map out and understand better what are the for example, the barrier that they might face in managing patients and really implement a more intensified approach in their daily practice. And ideally, this better understanding of the urology community should trigger an empowerment of this new group of experts. So we wanted to have a urologist in the future to be advocate for an intensified approach, because they believe in the need for these patients to receive treatments that can really have an impact on their outcome, and not rely on the outcome that they know today based on a consolidated practice for them. Also, we wanted to build a partnership with the urologist community. This is something that you will see more in the TSP. How can we partner with them to better understand their need, but also to develop, co-create projects that can advance their awareness and also help them implementing smoother process at their institution. The third element of the GeoCare pathway as element of commonalities with the urologists. Also for the GeoCare pathways, we have today a situation that is quite fragmented based on the country level, at institution level. So definitely one of the priorities today will be to better understand and map out this care pathway, looking at the different specialties, how they interact, how they work together, but also where the patient journey, where the workflow doesn't work well. And that is the space where we can partner with them and look at solutions to improve these pathways. This in the future will translate in a more effective collaboration for MDT. And then maybe also there are nuances in terms of MDT. In some situations, the MDT is really based on multiple specialties working together. In others, maybe we might see simpler model where the collaboration is especially between the medical oncologist and the urologist. But regardless of the composition of the MDT, we should be able to support and facilitate a more effective collaboration. This will be critical also for the new stakeholders that we are engaging with the radioconjugates, so specifically nuclear medicine and radiation oncology, and in particular how this new pathway can be improved for the patient. So when it comes to administration of radioconjugates. The patients also will play a critical role, because with a more complex scenario in terms of treatment option and treatment pathways, we want the patient to be able to have an informed discussion with their physician and be part of decision making. Okay, if we can move to the next slide, Gero. I think someone might have their mic open. Thank you. So in terms of activities to support the three strategic imperatives and the critical success factor, you will find a bit more in the TSP. this is an overview of some of the key global deliverables, but also we try to provide some prioritization, a sort of prioritization for the countries on the projects that should be imminent focus. Because really we support our strategic imperative and critical success factor. You will see several activities around the need to empower physicians to have a more informed approach and awareness around the intensification of disease. So you will see a few projects around evidence generation, for example, in collaboration with the EU for the Euro Evidence Hub, but also you will see several programs with the educational purpose, really to increase awareness around the need to intensify treatment. We also want to co-create activities that can help, can allow us to engage with the urologist community, but at the same time allow us to speak their language. So making sure that when we look at an educational activities or, for example, the publication plan, we really understand what are the needs for this community, what are the drivers, and making sure that we can really focus on the areas that are most important for them. One of the key projects you will see is really try to execute a one GU segmentation for the urologist. This will be a critical factor for success because we wanted to make sure that we have a consistent segmentation across assets and across bladder and prostate. So this will trigger also more consistent KE engagement plan. So in order to make sure that when we approach urologists, regardless of the assets, regardless of the tumor type, we have a similar approach and we can really find the synergies. And the third element, the third area of focus is really around building this MDT and making sure that supporting the physician, the scientific community in building more effective MDT and making sure that really the experience is positive for both the patients and the physician. So with this, I will hand over to Kelly for an overview of the go-to-market model.
Have we addressed the question in the chat on Niagara 2?
Sorry, I wasn't reading. I think
yes,
Samin replied.
Samin answered the question.
Yeah.
Excellent. So thanks so much, Lisa. And I don't know how you can't be excited by what we have ahead of us in the GU space based on what you've seen so far. I think the next question is, how do we implement on all of those opportunities that we have? So certainly, the GU space is increasing in terms of scale and complexity, and we believe that that's going to require specialized resources and capabilities. We really see that happening in two different phases. So the first phase is focused on what you would define as your MTP period of time. And this is really where we need to focus on the launches that we have ahead of us, most significantly within bladder cancer. Many markets have already transitioned to a GU-focused field team, whether it's in MSLs or your sales team. But if you have not had the opportunity to do that, that would be our first ask, is that you move to a focused field team, just given the complexity and the amount of opportunities that we have internally that we want our teams to be experts on, as well as understanding the competitive environment. What we've put here is some guidelines in order to help inform when you might do that within your market. But again, we see Potomac and Evopar Prostate 1 as two of the major triggers where you could look at specialized field teams within your markets. The second phase is really when we look at preparing for our radioconjugates, and that's more about capabilities that we need within the organization. And we can speak more about what those capabilities look like, but it's less about transitioning current resources into radioconjugates, but really looking for where is the expertise that we need and how do we bring that within our organization. The next slide, Fred, if you can move, really speaks to how our focus is going to shift both today, tomorrow, and the day after tomorrow. So what you'll see here is an illustrative bar graph, yellow being bladder, pink being prostate, and CAPI sort of being in between. CAPI is hatched like that just because each market has a different plan for CAPI in terms of ability to commercialize. So that's something that may sway differently from market to market. But generally what we believe is that the focus should be on bladder cancer in the today, so that we can really realize the launches that we have with Niagara, Volga, Potomac, and Nile. Obviously still keeping focus on Lynparza in terms of making sure that we are optimizing biomarker testing and really realizing the opportunity that we have in prostate cancer, as well as starting to do some market shaping for Saruparib. But generally, the focus really should be on how do we solidify leadership within bladder cancer. As we shift into tomorrow, so 2027, 2028, again, depending on your market, that's where you're going to see that shift from bladder cancer to prostate focus really start to happen. So again, we're making sure that we are competitively differentiated within the market spaces that we are for bladder cancer and really pulling through those launches. Potomac will be our biggest opportunity. As Lisa mentioned, this is almost $1.5 billion globally, so a very significant opportunity for bladder cancer. But this is also where you will start to do more significant market shaping for Evopar Prostate 1. So right at the tail end of this space is when our first launches will be occurring, and we want to make sure that we are ready for that. And finally, when we get into the day after tomorrow, that's really where you're going to see the focus really shift over to prostate currently, based on making sure that we're pulling through launches for EvoPro, but also this is where the radioconjugates are really going to start to launch. So this will be a significant area of focus, and you will continue to hear more about what we need to do in that space to prepare as the team is building up that plan. Lisa, do you want to speak more about that?
Yes, absolutely. And sorry, can we go to the next slide? Thanks. We already touched some of the elements that will be areas of focus for radioconjugates, and this slide is really to spark some excitement and give you a heads up of what is coming and the ask for the countries. So in terms of success factor to launch radioconjugates, there will be elements that are part of our launch also with other assets. So definitely we will have scientific exchange. We will build a strong narrative around the mode of action, and we really need to focus on the unmet need for these patients. But at the same time, this launch will be characterized by elements that are somehow new, because the radioconjugates are something are quite specific and different from other assets that we have launched so far. And definitely the nuclear medicine will be expert will be a huge area of focus for us, because this is a group of experts we don't usually engage with. So we need to understand who they are and again, how to work with them. And alongside that, we need to look at new modalities to identify patients, specifically PSMA PET imaging for Xadago. The manufacturing process and the supply of the drug will be another important area of focus, because as mentioned previously, The experience needs to be positive for the patient and the institution, because the time window from the delivery to the administration to the patient is very, very stringent. We know that not all the center will be able to administer radioconjugates, but we can expand the number of centers, as Gero alluded to previously. So how we will work with them to facilitate for center to get their license, that would be another critical aspect of our launch. And then the logistic to make sure that the institution can receive the drug in time, but also for studies beyond the clinical program, how can we make sure that we can provide the drug and for ESR, for example, or GMA-led studies. In terms of focus for 2026 and 2027, this year you will see main focus from a global perspective and IBT, while the IBT is working on the market shaping plan that we are presenting later this year, and on building internal capabilities, but also really start to build our external engagement strategy. The ask for the countries will be at this stage, especially focus on helping us identify center for our clinical program, expanding beyond centers that were engaged by Novartis for their studies will be a critical success factor for the launch, but also really start planning for resources in 2027 and beyond, because even if the first launch will be in 2030, this specific area is so unique, so peculiar, that we require to have resources in place starting with 2027 and start building market shaping activities at a local level. I will stop here. I think, Gero, Kelly, we have a few minutes for questions if there is something not addressed in the chat yet, or if someone wants to use the mic.
Yeah, 5 minutes left for questions if anybody wants to come forward. If that's not the case, maybe we can just briefly go back one slide to the go-to-market model recommendations. I think in previous conversations, we've realized that this is probably going to be one of the hardest things to get right here. Lots of competing priorities. Jan, and yes, we'll share the slides if you couldn't download them. Just thinking here about the go-to-market model, we realize that any shifts in resources between bladder and prostate may occur at different time points, depending on your local market timelines for launches, of course. And then also the dynamics of shifting medical resources are different than those of shifting the commercial resources. I think what Kelly, Lisa, and I had discovered is going to be, tricky, but we'll do the best job at managing it, is when we move from today to tomorrow, where today we really need to have that rigorous focus on maximizing and doing a great job on the bladder launches. When we move into the tomorrow scenario, and thinking about launching saruparib, there's probably a shift that happens earlier on the medical side and then later. And for most countries, probably rather in the 2029 space when the commercial part is shifting. Again, depending on your local reimbursement timelines, most markets won't launch saruparib before 2029. Hence, there's probably not so much of a crunch in the tomorrow scenario on the commercial resources, but there may be a bit of a crunch on the medical side. And then, as Lisa already pointed out, we're going to give more guidance on MTP with regards to specifically dedicated capabilities and resources that are going to be needed to be successful for launching radioconjugates, which is, as we've seen, a very different business model and really follows a couple of different rules. But more to come on that as we get closer to MTP. We have a question from Jan on diagnostics. How can we optimize diagnostics across the prostate cancer portfolio, thinking about ctDNA? Any thoughts, Lisa? We do have a couple of slides in the deck on prostate diagnostics strategy that may be helpful.
Yeah.
Would you, sorry, this is Cam here. Would you like my perspective from a diagnostics?
Oh, you're here. Yes, please.
Yes, sorry, just in a
Cameron.
room here downstairs. Hi, everyone. Cameron Porter here. I'm the Global Medical Affairs Lead covering diagnostics for GU. And it's a great question. So as we know, there's biomarker overlap. There's several biomarkers that we're trying to push out in prostate cancer across MCRPC and MHSPC. And as you can see, the day after tomorrow into the adjuvant setting as well. We're not alone here. We have a lot of competition. There's a lot of varying biomarkers, and a lot of this education and infrastructure, I guess, builds are focused on urologists as well. So there's 2 points I'd like to make. One is that it's from a messaging perspective, it's critically important that the markets maintain share of voice here around what HRR is, as well as PTEN testing. I would say this regardless of your launch plans currently, as this is a space that we will be entering as a priority for most markets with EvoPAR Prostate 01. And we do not want our competitors basically driving their biomarker narrative in isolation. So that's just one point I would like to make. So a call to action for the markets to continue that share of voice around that awareness and adoption of biomarkers as HRR, and obviously beyond. Regarding the actual platforms as well, we know that ctDNA in prostate cancer is very appealing, but offers a lot of challenges in implementation. Probably the greatest challenge that we're seeing across all the markets is the clinical utility case and the economic utility as well of ctDNA. It seems to be quite a big challenge, and we are doing work at a global level and with the GDX teams on trying to build out assays that can be utilized at a lower cost. However, at this point, again, it's more around education and awareness, and in the markets where you have access to a validated ctDNA assay, is working at a local level to ensure that you can come up with an access point there. There is ctDNA embedded in basically all of the trials as well. However, we'll have to see how that pans out for us to roll through. I would also call out, just additionally to that, the digital pathology as well, looking for local solutions to streamline testing, leveraging digital pathology. So ESRs and studies that embedding this sort of technology into clinical workflows are also, of interest, at least to me, to learn about as we want to expand the breadth of evidence that we have there. Yeah, and this is a great slide. I think the straightforward stuff like PTEN deficiency testing with IHC, I'm not too worried about. But as we move earlier on in the disease setting into localized, we want to make sure that we've got very robust testing pathways and economic use cases for them.
Good. We are pretty much at time, but if there are still some questions around the EAP, Lisa, Kelly, can you answer those or?
Yes, so I answer in the chat regarding Potomac. We are planning a real-world evidence study to look at the effectiveness of the regimen utilized within the EAP process, and the EAP program, and the program is starting right now. So patients will be enrolled moving forward. So we don't have patients enrolled yet, but is kicking off right now.
Good, very well. We're pretty much at time, and I would like to thank all of you for taking the time to join our call and for being so interactive with us, making this a really fun rollout. Thanks a lot. We are continuing here at global level to see now how we pivot to make this plan a reality. We are soon to announce the formation of our global GU tumor commercialization team that will move forward on priority projects that we have presented to you in the plan. And that will, in the first instance, be about really kicking off the 1GU urologist segmentation so that we can work off one segmentation that we can deploy across disease areas for our GU field teams, making their life easier. And then, of course, going all in on the work we are going to do on pathway optimization, starting with MDT work and MDT maps. That is the next priority that we're going to address immediately. So thanks a lot for your time today, and we are looking forward to continue to interact and keep you updated on how things are progressing. Thank you very much. Bye-bye.
Thank you, everyone.
Thanks,
Thank
everyone.
you.
Bye-bye.
Thank you. Bye.